Hi guys, I've got some questions that people have been sending in. Where did I actually send them to, Gail?
They can message them, email them.
Okay, so if you have questions, you can email the email address on restoringexcellence.com.au, or you can go to the Facebook page and send them as a private message. So if you have questions that you want me to answer, send them through and I'll do a video in the future and answer those. One of the questions that's been sent to us: which material would be the best to make a 3-unit anterior bridge in a non-bruxer with limited occlusal clearance? Abutments are endo treated with post-core and crowns. Okay, so 3-unit anterior bridge, limited occlusal clearance, endo treated cores and crowns. So you can see we're starting to get multiple layers of risk going on here. So the number one thing is to tell the patient this is a compromise. I don't know why the question person hasn't told me why there's limited occlusal clearance. Maybe it's because it's a deep bite. Maybe there's a worn dentition, I'm not sure. In general, when we don't have a lot of room, the best thing for anterior work is a PFM with a metal back, because you can make a metal back thinner with less risk of fracture than anything else. So PFM with metal back, of course that means that you need to prep a margin on the buccal, otherwise it's going to look awful. And then you'd have to consider things like that. And then of course you want to talk to the patient about maybe having more space. So more space would come from doing ortho or doing a occlusal vertical dimension increase. So in general though, if you have limited room on the anterior, you should do porcelain fused to metal with metal lingual. The second best, I guess, would be full contour zirconia, but zirconia in thin sections I'm still not convinced about. I don't have long-term cases. So what I do know about zirconia is when it cracks really fast. So it's not like metal where it slowly wears out, it goes bang and then it's gone. So I would tend to stick to PFM in limited occlusal clearance cases. Next question is, if you do cause a mechanical exposure during tooth preparation, would you pulp cap it and proceed with a crown, or would you monitor for a few months if asymptomatic crown, or would you proceed to RCT and then crown? So if you are routinely hitting the pulp while doing crown preps, you need to have a good long think about yourself, okay? It shouldn't be happening very often. If you hit a pulp that you're not expecting to, that should be rare. Now, the most common spots to hit the pulp is either anteriors, where you're trying to correct angulation so that you can do a bridge or something like that. So you've got the canine and the central are slightly divergent, you're trying to do a bridge, and so you've got to upright them and parallel. That's obviously a risk and you need to warn the patient beforehand. The second place that pulp exposures occur is on back teeth that have massive pulp horns. So always look at your x-rays and look at how big the pulp is. If the pulp is massive, then maybe don't do a crown or increase a vertical or whatever. So those cases. Now, the other time that occurs is when you take out the core. Obviously look at your x-rays first. If the core is deep, then warn the patient about the possibility of root canal. If I'm doing a crown, no, I wouldn't do a pulp cap. So if I'm planning to do a crown anyway and I expose the pulp, I would do endo. The problem is that if you do a crown and then, a short time later, the tooth blows up, first of all, the patient is less happy. Doing endo while the pulp is still vital, yes, you remove a little bit of tooth structure, but if you do a small endo, you don't have to do massive fat endos with huge tapered files. You can do skinny little endos. And if you're doing it in a vital tooth, the success rate is really, really high. So why not? Pulp capping, I'm not convinced about yet. Okay, some people do it and they say it's really successful. I just know that if you've got a pulp exposure and you're going to do a crown, I would do endo. Okay, now another question. Do all ridge splits resorb? No, all ridge splits don't resorb, but when you make bone very thin, it resorbs easily, and how much is a little bit hard to tell. So ridge splits are something that seems like a good idea until you do quite a few of them, and then they don't seem such a good idea. So there's not many people that I respect really well who do lots of ridge splits. If you're going to save so much trouble to cut a piece of bone off, just do a Curie plate technique or something a little bit more reliable. The problem with ridge splits is because you often get 1 to 2 millimeters of resorption, you have to put the implant quite deep and you don't know how much resorption is going to occur. So ridge splits with simultaneous placement, I would no longer do. The other issue you have with ridge splits is that the lingual or the palatal bone is much harder than the buccal bone, particularly when you split. So when you do a split, it is quite common for the implant to end up tilted quite buccal, because as it goes in, it hits that hard bone and it pushes the split further to the buccal, and you end up with mal-placed or mal-angled, poorly angled implants. So ridge splits, I don't do them anymore. How do you develop the confidence to try a procedure you haven't done before? You can only develop, so this is about overcoming fears, and some people are better at this than others, and that's a personality thing. So you want to think about your personality, and do you really want to get good at procedures of various sorts, or are you going to be a lot happier if you restrict the number of procedures you do and become very good at them? So that's a personality thing, and you should not everyone should try and do what I do, and I certainly shouldn't do what other people do. So just because I do many procedures doesn't mean that you should. Some people's lives will be much happier if they restrict what they do and just do the same things more routinely. Now, the confidence only comes from doing something. So when you are afraid of something and you do it anyway, then you get the confidence. So you can't get the confidence and then do it. It has to come from doing something that you're afraid of. Okay, and the general cycle is this: you will be afraid, you'll do the thing anyway, it'll be quite stressful and anxious, and then you'll develop overconfidence, and then you'll make a whole bunch of mistakes. Then you'll go through depression, where you avoid the procedure, and then you'll reach happy medium. So that process takes maybe 2 to 3 years. Everyone goes through it with a new procedure. So things to prepare for doing a new procedure. It is good to practice. I practice most procedures, so I practice composite resins on models from time to time. I practice a lot because I teach. So when I'm teaching someone how to do fillings, I end up doing, they might get taught to do 10 fillings, and because I fix or correct so many, I end up doing 50. I practice a lot on models. I practice a lot on patients who are not paying. So I have patients, for every procedure I've done on a patient for free. So I've done, I don't know, maybe 6, 7, 8 full mouth rehabs for free to learn the skills over time, or to learn how to do implants for full arch cases, or so on. So developing confidence, it helps if you build the skills up a little bit. So if you start with smaller things, the skills we use for smaller cases work on medium cases, and the skills we develop on medium cases work on big cases. So that's why with the continuum, I start you out with, you know, doing a few back teeth, and then we move up to doing multiple front teeth, and then we go up to full arch on a model, and then add the soft tissue work in, and then we suggest you do the live patient course, because you've built the skills up and you're being mentored and supported through doing your first cases. So to sum it up, to do things for the first time, you should have some hands-on training to build the basic skill. You should be mentored, if possible, through your first cases, and just accept the fact that you will be afraid of the procedure until you've done it a few times. You can't avoid being afraid, and in fact, if you aren't afraid of doing new procedures, you're probably a hazard to yourself and others. So it's healthy to be afraid of a procedure. The confidence comes from doing something that we're afraid of. Here's the same question. It's basically the same question again. How do you overcome fears or face the struggle of performing a procedure that has in the past failed? So this is a very important part of dentistry. We fail and we avoid the procedure. And this happens to me a lot. I went through a big implant slump. I had a whole bunch of cases that didn't go well, or the patients complained to our regulator here. And then I realised, you know, that's inner growth, understanding that some of the cases I probably shouldn't have done, or I should have done differently, or more slowly, or done better. But it's very difficult to teach that, because that's called experience, and you can't teach experience. So it's kind of like, how do you get back on the horse when you're thrown off? It's a gradual thing. So when you get thrown off your horse, you're going to avoid the horse for a while. So when you have a big implant cluster, so implants don't fail regularly, you'll go a whole bunch of time with no failures, and then you get a cluster of failures. You get a bunch that all fail at the same time. So that clustering is what hits our confidence. We get the same with blocks. We can numb all our patients up properly, and then we get 5 or 6 blocks that don't work in a row, or whatever type of anesthetic. So the struggle, usually it's a slow process. Over time, we slowly forget that it was so dreadful, and then we have one case that turns out okay, and that builds our confidence, and then so on. Sometimes it's helpful to train. We tend to avoid courses in the areas we don't like, or which were painful, or which we're a bit nervous of. So often what I do is, if there's an area of dentistry where I'm avoiding it because I'm a little bit afraid, then I will actually focus on training in the things that I'm afraid of rather than avoiding. So I will do more education if I'm afraid of something rather than avoiding what I'm afraid of. But it's a struggle, and it just takes time usually. Usually it takes time. You fall off, you take one little case, another one, and over a year or two. It often takes 2 years to get back on your horse after you've been kicked off. So if you feel like that's what's happening to you, that's normal. Happens to me all the time.